heavy workload. Hardly any private life. Lots of responsibility. Always pushed to the limit. Whenever I ask doctors and nurses why they take all of that on, they often say, because what I do has meaning. Meaning for the lives of others, and therefore for my own life as well. As a global forum for medical specialists, we asked ourselves, how can we most effectively support the work, ambition, and dedication of these individuals? We sought out dialogue. We listened, and we understood. With a supportive exchange among medical professionals who network their knowledge around the globe, so that they maintain their expertise at the highest level for their entire lives. With disciplinary approaches that promote specialization without losing the perspective on medicine as a whole. With smart, modular concepts that are compatible with the busy lives of medical practitioners and nurses. With offerings whose contents provide answers for the reality of everyday medical life. With a growing perspective on trends that enables medical practitioners to already prepare for future challenges today. In close dialogue with renowned specialist companies that bear testimony to the quality of the offers. With inspiring forms of learning that don't just convey knowledge, but make it an experience for the senses. And with innovative teaching methods that prepare you not just for tests, but for life. Nurses and care assistants, physicians and hospital managers, and the people who work in the home healthcare services sector. All of those who teach and learn at the Esculap Academy share a passion for excellent medicine and very high personal standards. We invite you to join in a dialogue about health and medical care. A dialogue that is dedicated to life.
Sharing knowledge, learning something new, gaining confidence, thinking medicine, improving health. This is what drives people at Esculap Academies all around the world. And this is why we communicate with one another in a dialogue that is dedicated to life.
All around the world, both speakers and participants, as well as researchers and practitioners meet at Esculap Academies in order to think medicine further ahead. Is there anything more valuable than a dialogue dedicated to life?
The Esculap Academy connects people who want to know more, to improve medical care. They are looking for a dialogue. We offer a dialogue dedicated to life.
Dialogue dedicated to life.
对话致力于生命健康。
Diálogo dedicado a la vida.
Dialog посвященный жизни.
Dialog dedikasi bagi kehidupan.
Dialog dedykowany życiu.
Dialogue dedicated to life.
الحوار مكرسة للحياة.
Diálogo dedicado à vida.
Dialog pro život.
Become part of this international, interdisciplinary dialogue at Esculap Academies all around the world. A dialogue dedicated to life.
Good morning and good evening, ladies and gentlemen. Welcome to the Esculap Academy Medical Education Platform, a B. Brown company. My name is Linda Duyanti on behalf of the Esculap Academy, B. Brown and the Pain Institute of Indonesia. We would like to extend our thank you to everyone who have joined in this morning in this digital dialogue series of Interventional Pain Update, Episode 1. And we're also delighted and honored to have our distinguished panel of expertise who have joining us today, this morning. Thank you all the way live from Iran and also from Semarang, Indonesia. Thank you. And I would also like to highlight the agenda for today. It's about 1.5 hours today we will be together of this sharing session. topic from Dr. Helen Gharaei from Iran will be highlighting about the ultrasound guided lumbar spine injection. And then we'll be hearing presentation from Dr. Shofwan on the fluoroscopy guided interventional procedures in low back pain, pitfalls, and potential complications. And you will all be shared your questions in the Q&A tab today, if you'd like. That is okay. And Dr. Yosi will lead you with the panel discussion with all the experts. And then closing remarks. All right, and we have faculty of today. There's also an important messages that we'd like to convey. Please be noted that your microphone is muted throughout the session. And also, please post your question in the Q&A section anytime throughout the session. And please kindly be reminded that this session will be recorded. Our faculties of today. We have Dr. Helen Gharaei from Iran. Good morning, Dr. Helen.
Good morning.
And also we have already here Dr. Shofwan from Semarang, Indonesia. Good morning, doctor.
Morning, hello.
Yeah, and it is also an honor for me to introduce this next expert figure. We have been in collaboration with him for a few years back now. He's a member of the Indonesian Society of Anesthesiology and Intensive Therapy. He is also the head of the pain clinic in Tarakan General Hospital, Jakarta, and of course, a chairman and director of Pain Institute of Indonesia. Ladies and gentlemen, please welcome our moderator of today, Dr. Yosi Asmara. Please, doctor.
Thank you, Linda. Welcome, everyone. Good morning. Here from Jakarta. It is an honor for me to be here and hold this important webinar with you all from all around Indonesia and all around the world. And thank you also for the participants who are able to join us this morning and afternoon, maybe in the other area, and evening. We have more than 500 participants registered from all over the world. US, Middle East, Africa, Europe, India, and of course, my fellow colleague in Indonesia. Thank you for attending this webinar. We know that since the pandemic of COVID-19 hit, webinars have been very popular media in delivering training and education. I hope in this YAP Talk or YosiAsmaraPain Talk sharing session, it will not only be valuable for all of us, but also the very important is valuable also for the patient. I've been doing this pain intervention for around 7 years. Starting in 2013, when I first founding and running Tarakan Pain Clinic in my hospital, Tarakan General Hospital in Jakarta. And I met so many friends when I took my FIPP certification from WIP in 2016. I met Helen too. In Hungary, and also in 2017 for the CIPS certification, Certified Interventional Pain Sonographer in United States in 2017. In 2018, I started to set up a Pain Institute of Indonesia. It is to create continuous interventional pain education for Indonesian doctors. We make serial workshops in Indonesia, like pain diagnostic, ultrasound guided interventional pain for musculoskeletal, ultrasound guided interventional pain for spine, and ultrasound guided interventional pain for the nerve. And today, it is an honor for me to welcome two of my colleagues. The first one, my beautiful friend, Dr. Helen Gharaei from Iran, who will give a presentation about ultrasound guided injection and procedure in the lumbar area. And the other guy is my friend, the young rising star of pain intervention in Indonesia, Dr. Shofwan from Semarang. So the first will be Dr. Helen. I will read the CV of Dr. Helen. Dr. Helen has completed her medical doctor in the Mashhad University of Medical Science and postdoctoral studies in anesthesiology in Uremia University School of Medicine. Gained her pain fellow degree from Tehran University of Medical Science from Iran and FIPP degree, Fellowship of Interventional Pain Practice from Texas Tech University, USA. She is now a private consultant pain specialist in Tehran, Iran. She has published books and many papers about pain management in reputed journals and has been serving as an editorial board. She invited as a speaker in many international pain conferences from the beginning of her professional career in the field of pain. She is the pioneer of ultrasound-guided spine injection and participated as faculty or trainer in many cadaver workshops of ultrasound and fluoroscopy-guided pain injection in many countries. She's constantly contribute to the growth of the pain medicine worldwide. Okay, so this is time for Helen. Okay, Helen, are you ready?
Yes,
time
thank
is
you.
yours now. You can present your presentation, please.
Thank you, Yosi. Thank you for introducing me. Thank you, Linda. And okay. Hi, everyone. I wish you and your family are well and safe. I heard that there is about 500 registration for this webinar, and it is a great news that despite we are facing a global humanitarian challenge, but we found our way. Really, we need a journey that inspires, motivates, and sometimes overwhelms us. In fact, the pandemic breaking down barriers and brought us closer together from 38 participant countries. Thank you for registration. Thank you. I want to talk about ultrasound guide lumbar spine injection. We need a transition from fluoroscopy to interventional ultrasound guide injection. Over the last decade, the use of ultrasound in the field of regional anesthesia and pain medicine has increased exponentially. Ultrasound as a portable and accessible device has attracted the attention of pain specialists too much, and today it's used for a spine injection. But the spine injection is a little bit difficult compared to other ultrasound guide injection. But you can use landmark, which you always use fluoroscopy guide injection, and you can use the same landmark for ultrasound guide spine injection. As we tell, landmark is the core for fluoroscopy guide injection. Fluoroscopy guide injection could be a basic for ultrasound guide injection, although it is not necessary. For the first time in 1971, Begin and Stolin were the first anesthesiologists who used ultrasound for epidural injection. Then Cork identified its landmark and improved this technique. Keris and Wallace in 1992 definitely helped us and showed the landmark for epidural injection and introduced it to the literature. In 1997, Kalmir described ultrasound facet injection. And but during 2007 to 2015 period, Galliano and Gharaei worked very hard and introduced us a medial branch block, L5 posterior primary ramus injection, and finally transforaminal injection, which is more difficult and challenging, and I will discuss about it today. This is why ultrasound guide injection is appealing, why every people around the world love to learn this. Because I think this is a necessity today. Ultrasound is not very expensive compared to fluoroscopy. Ultrasound is safe. There is no X-ray radiation. This is a portable and applicated device. There is no limitation when we have difficult position, and it's more practical when you have a difficult surface anatomic landmark. Although you can see the anatomic difference in your patient, I found it even spina bifida in the lumbar of my patient when I check in the ultrasound screen. And you can, the most important part is that you can visualize and localize a specific target. In fluoroscopy, you can see just the bone, but in ultrasound, you can see skin, soft tissue, vessel, and also the bone. And so you can localize your specific target. And you can easily maneuver the probe. And you don't need to help your assistant to turn the C-arm, AP, oblique, lateral. Just move the probe. Axial scan gave you an AP view, and the sagittal scan give you a lateral and oblique view very easily. And even you can use Doppler and localize the vessel, and this is very important for a spine injection. And it's proved that ultrasound guide injection improve efficacy and safety. You have faster, denser block, higher block success rate, lower volume, and it's very important for you. And in a spine injection, you can see the posterior element. With fluoroscopy, you could just see the vertebra, but with ultrasound, you can see dura. And it's very important. It increases your confidence when you use ultrasound for lumbar injection. And finally, I believe it that ultrasound can be a gift in developing country if used properly. Due to its low cost, portability, it can be used even in deprived area. Even the high prevalence of low back pain in the community, learning ultrasound guide lumbar spine injection will greatly contribute to improving the quality of the life of the people. Okay, but we have to know the limitation of your device also. What's the limitation of the ultrasound guide injection? Maybe for novice, it may take longer procedure time. Maybe you have to use larger gauge when you are novice for injection to visualize the needle in the screen. And in obese patient, maybe it would be a little difficult, and in elderly, because of degenerative joint disease, it is a little difficult. And intravascular injection. Although ultrasound show you the vascular structure, but in deep structure, it's a little difficult to visualize the vascular structure. Except when you have a good device. And in failed back surgery syndrome, we have reverberation, the artifact due to metal instrument, ultrasound back and forth between two strong reflector. When patient have instrument in the spine due to spine surgery. But in my experience, when you use multimodal technique, combination of fluoroscopy and ultrasound, injection in this patient is very, very easier. And the most important point for ultrasound is learning curve of the probe. Because of some anatomic structure, for example, sacrum has such curve, and putting the probe is a little difficult. You have to touch between the probe and the body to see a good view. But this learning curve may be difficult in sacrum in some patients. Reporting many cases of carcinoma after chronic C-arm radiation exposure shows the importance of ultrasound guided spine injection. It seems we really need to up to date with this technique. Okay, how to perform ultrasound guided lumbar injection? First, you have to know ultrasound examination performed with a curved probe, and you have to find 4 some important sonoanatomic structure. First, it's very necessary that you improve your knowledge of sonoanatomy, then enter your needle for patient safety. And the first step is to determine vertebral level. Remember, we don't want to use fluoroscopy for determine all level. We just want to use ultrasound and determine all level, and I will teach you. The second step is to find 4 parallel sagittal lines. First, interspinous process line. Second, interlaminar line. Then pedicular or articular line. And then intertransverse process line. And the third step is to find a Z-joint or facet joint. And finally, the most difficult part is lumbar periradicular injection or transforaminal injection. Okay, first step. For the first step, put always use a curve probe in a spine injection. Even in teen patient, you use curve probe. And always use, consider the depth of 10 or 9 centimeter for scanning, because your eyes might have to learn just one kind of picture. When you change the depth, the picture changes. So always use 10 centimeters depth. For scanning, put the curved probe longitudinally in the paraspinal space about 4 centimeters lateral to spine or midline, and on the ribs, on the lower ribs. You know, rib have a unique feature in a screen, and the 12 rib, the last one, is short and has an end. You can see here. This is the end. This is unique picture that you have not in other ribs. So you can diagnose you can see the 12 rib in a screen easily, okay? Put the probe and scan from the rib and then you will see the 12 ribs. And then when you downward the probe, you will see the transverse process. These are transverse process, and transverse process are different from the rib because ribs is thinner and longer, but transverse process are thicker and shorter, and they have the same length. See, the same length, and you can easily diagnose transverse process. And always we have a hyperechoic tape, yeah, hyperechoic tape on the any bony structure, spinous process, transverse process, lamina. And this is because ultrasound wave couldn't pass from the hard bony structure. This is like when sunlight cannot pass through our body and create a shadow behind us. So consider this. And then when you come down, and this is the L4 transverse process, this is the L5, and this is the sacrum. Sacrum is a curved hyperdensity here, and you can diagnose it. So, and this is not very clear, but we'll show you later. SIP of the S1, and it maybe you confuse it with transverse process of L5, and I will show you in other picture. Okay, when you find your design level, for example, L5, L4, L3, then move your probe is like this longitudinally, and you have sagittal view, then move your probe 90 degrees clockwise. On the design level, just put the design level on middle of your screen and then move it here. So you will see the design level. I will show you in a video. And this is the sagittal view of the spine. This is spinous process. Always you have a hypoechoic density here. This is a spinous process. And when you scan from up to down, you will see different view of a spinous process, and the length of the spinous process change gradually. And it's to find a better view of the level, you have to have a longest view of this shadow of a spinous process. This is where you can see the spinal canal, and facet joint and transverse process. So when you use you want to counting the vertebra, use the axial view that show you the longest spinous process, shadow of spinous, acoustic shadow of spinous process, and therefore you can see the spinal canal, lamina, facet, and transverse process in one view. Okay, this is what I told you. Put the probe longitudinally here on the ribs, and you will see the 12 ribs, and gradually L5, L4, and always put the level on the middle of the screen. And gradually other level you will see. Okay. And the probe is come down. This is the sacrum here. Here, and this is SIP of the Swan. Don't confuse it. You can get a good view. Don't confuse it with L5 transverse process. Then move the probe to transversely, and get a sagittal view. See, this is the long spinous shadow of spinous process, and its length change. When you move the probe, its length change and get you different view of Z joint, SIP, IAP. And always consider that SIP up to transverse process and IAP lower to transverse process. You see the length of the spinous process change. Find a view that has the longest spinous process. Again, I repeat this video for you, okay? See, the length of the transverse process and acoustic shadow is at the same level, and these are transverse process. Don't confuse them with the rib. The probe is still longitudinal. Then, after choosing the level, turn the probe transversely. Now I turn the probe to get a view of axial scanning. Long spinous process. This is a good view. We have a long spinous process. See the length of the spinous process change? Yes. Transverse process sometimes come into your view. Yeah. Okay. In the end of scanning of the axial scanning of the spinous process, you will receive to L5. And then when you move downward your probe on the sacrum, you will see this. This is median crest of the sacrum, which really is a fusion of a spinous process in the sacrum region. And it is very short. When you move your probe from lumbar region to the sacrum region and see this acoustic shadow, you are on the sacrum. When you move your probe down, you will see the cornea. This is the site for injection in caudal injection, and I will teach you. And consider that the sacrum is a large triangular shaped bone formed by fusion of 5 sacral vertebrae. It has a blunted caudal apex that articulate with the coccyx. If in dorsal surface is convex and has raised interrupt median with 4, sometimes 3 spinous tubercle, and represent fused sacral spine as median crest. And consider that sacrum is has a posterior surface and anterior. So the injection is done here, and between posterior surface and anterior surface. Consider it. When you want to inject in caudal canal, you need this. Okay. Move your probe from here down to here until at the midline. Always it must be on the midline. You see the cornea. Cornea is hyperechoic. This is because of the shape of cornea. This is really unfused S5 SLP. You see here hyperechoic, and acoustic shadow, which is round. Acoustic shadow depends on the shape of the bony structure. Any shape that bony structure have will have the same acoustic shadow, like the shade of us into the wall. And here you have sacral cornea, and between sacral cornea and always it must be on the midline. This space must be on the midline of your screen, and cornea must be here and here, and here must be just on the midline. And consider there is hypoechoic here. This is sacral hiatus, and this is hyperechogenicity of the anterior sacrum. And here is sacrococcygeal ligament. It is a little hyperechoic. Between them is hypoechoicity, which is the caudal canal. You can use this landmark, this blind landmark, and still the probe is transversely. You have to enter your needle here and don't move it, because when you also need a sagittal view. When you move your probe from here, put here the needle. When you move your probe, your probe slide. So when you put a needle here, it prevents sliding of the probe, because for caudal injection you need a sagittal axial scanning and sagittal scanning both. See, this is a sagittal scanning of the caudal canal. You see, this is the sacrum, anterior density. As I told you, we have two bones, and this is posterior. This is the sacrum. This is coccyx. And between them, we have a gap. This gap is more clear here. This gap is the site of sacrococcygeal ligament, which is a little hyperdense. For injection, you must enter needle in plane from here at the same site, and it must always be on the midline, and enter your needle here to this hypoechoicity. And it's really important that you have to put your probe just between two cornea, like this, not like this. When you see a very round hypoechoicity here, this is cornea. You can inject from here, but it's a little more difficult to find the space. It's better to put your probe longitudinally here, okay? And consider always that the needle tip should stay below S2 level to avoid tearing the dura. And it's about at the level of SI joint, consider it. And you can use Doppler to see the distribution of your drug. Caudal canal is very hypervascular. If you couldn't see this, it may be intravascular. And there is a technique that when you enter your needle to sacrococcygeal ligament, immediately stop and don't move it more. And this technique decreases the chance of intravascular injection and decreases the chance of postural puncture headache. Although it's not very common in caudal block, but I have it's case that after caudal block had postural puncture headache. So this is my technique, that when I enter the needle, penetrate the sacrococcygeal ligament, I stop the needle and inject my drug. Don't move it more and more. The second step is to find 4 sagittal parallel. If you could find these 4 sagittal line, you know all things about lumbar injection, and this is very easy. So the first line, always use care probe. The first line is here, between spinous process. You see in between spinous process, we have a gap, okay? And this gap will be seen on the ultrasound screen. This is the gap. And when you move your probe, consider your probe put longitudinally, okay? Then you move it very delicate step by step to the lateral. Then you will see this line. This is interlaminar line. Interlaminar line, there is a gap here. You see, this is a gap here and gap here. This gap is used for epidural block, and they called it window. You see here? This is not good view. I will show you in my video. This is lamina, this is lamina, and there is a gap here. That is the window for injection into epidural space. Then move it more lateral and put it on the pedicular line, about 3 centimeter or 4 centimeter lateral to the midline. And because we have here the pedicle, it is a continuous line. It's not like interspinous process line or interlaminar line. It is a continuous, just the continuous sagittal line is pedicular line, and you will see here. They told it is a Hamilcomb. Here is a joint. This is the SAP and AFP of the facet joint, and this is a continuous line. And then move the probe more laterally, about 5 centimeters. You will see here the transverse process. These are transverse process, and there is a large gap between them. We show you here. And this is transverse process, and gap between them is always used for counting. Okay, I have some question, but I will respond at the answer and question part. Okay, epidural block. As I told you before, you have to use a sagittal view of interlaminar line. Between lamina, this is the lamina, and this is the lamina. I will show you in my video, and it's very clear. This is the lamina, this is the lamina. Consider that every bone has an acoustic shadow, and this acoustic shadow depends on the shape of the bone. Because lamina is short and thick, the acoustic shadow is thumb-like, not like transverse process finger-like. And between lamina, we have this gap, this acoustic window. And in this gap, we have an space. And this is posterior compartment, and here is anterior compartment. Posterior compartment composed of ligament flavum, epidural space, and posterior dura. All of them is named posterior compartment. If you have a good device, you will see all of this. If you don't have a good device like this, you will see just one hyperechoic line. Okay, so, or maybe because of the obesity of the patient or some technical error. When you see just one line, when you see all the line, it's very easy to inject, enter your needle. But when you see just one line, it's better like this. It's better when you receive, consider the tip of the lamina. Tip of the lamina is about the ligament flavum. When you receive the tip of lamina, use loss of resistance to separate ligament flavum from posterior dura. And in this film, which is my last CADA workshop before pandemic in Lahore, I show you all the landmark. Look, this is horse-shaped appearance of spinous process on the midline. You must move very, very delicate the probe. And then you will see the lamina. Only a little change of the tilting change the view. Be very careful and move your probe delicate. Don't press on the body, push, just fix it. You must have very good hand, just fix it, okay? You see here is acoustic shadow of lamina, and this is posterior compartment, enter needle from here. Here is the posterior compartment, see? Up to lamina is ligament flavum, and hypoacousity is the epidural space. Just find a good view of the lamina and it is enough. Enter your needle about 45-degree angle in plane from here. First find a good view of the lamina. Always start from the midline. Enter your needle from here in plane, see? This is the needle. Push it toward here, between lamina. You always can use loss of resistance technique. It's no problem. Always, or you can use contrast injection and check it in fluoroscopy. Here, come here, and 2 dots here. See the needle? This is the needle. Okay, again, please look at this video. This is horse shape of a spinous process. Then move it more lateral to see the thumb shape of the lamina. Lamina. Look at my hand here on the body and see how delicate I move the probe. Lamina, lamina, and posterior compartment. Move, see the movement of the probe very, very slightly. Okay, this is the midline, and I'm here, interlaminar line, about 1 to 1.5 centimeters lateral to the midline. Failed back surgery syndrome is a syndrome after surgery of the spine. See the angle of the needle? This is the angle that you have to perform when you want to enter this space. If you want to enter this space, not need to do sharp angle. You can choose your space. Okay. The third step is to find the Z joint, zygovial joint or facet joint. This is very easy. When you put your probe transversely on the spine, this is the spine transversely, you, as I told you, you will see the spinous process. This is the spinous process. This is how you put the probe. This is the spinous process. Move it a little lateral after lamina. You will see this wavy appearance, two parallel line. This two parallel line is the facet joint, and it is a landmark for injection into medial branch block, as I told you here. This is a spinous process, acoustic shadow of a spinous process. This is the lamina. This is superior articular. When you a little tilt your probe, you will see superior articular very clearly. And this is the transverse process, very clear. You will see this high, long density, hyperechoic density near to SIP. This is the transverse process. And as I told you, you can use your knowledge about fluoroscopy guided injection, which the point of injection is between SIP and transverse process, this angle. Enter your needle in plane and move it to receive this angle and touch the bone. It's very important to touch the bone. And then it's necessary to check the probe, the needle side in longitudinal and sagittal view. This is sagittal view. You have to check that your needle must always be up to transverse process, not under the transverse process. Check that the sacrum is here and check for the marker here. Always there is a marker that, and your needle must enter opposite of that marker to show you where is you are up or down the transverse process. So when you see the sacrum, you check the transverse process and needle must be here. If it is here, you can move it on out of plan in sagittal view and put it here. It's very easy technique. Okay, we have some challenge when we want to inject in posterior foramen ramus or medial branch of the L5 exactly, which is a lateral branch. And we have this challenge in fluoroscopy also. But in ultrasound, you can use the same axial view, but like fluoroscopy, you must enter your needle with an angle. Cephalate to coded. Sometimes you can see this view, this view. This is SAP, this is the sacrum. Between SAP and sacrum, this angle is the site of injection. Sometimes some patients have high iliac crest and there is no space here to put probe like this, so you have to use probe and put it longitudinally and use the sagittal scanning. See, this is the sacrum, this is the facet joint. Here is the junction of SAP to the sacrum and the site of injection for posterior primary ramus. And always be considered that ultrasound-guided lumbar injection is a multimodal technique. Also, you use ultrasound, and always I use it for many years, about 5 years. And when I found my level, and first I inject 1 ml contrast and check for intravascular injection. Intravascular injection, although you will see the vessel on ultrasound, but as I told you before, deep vessel is challenging in ultrasound also. So then inject 1 ml of contrast and check for intravascular injection, because intravascular injection will cause a false negative block and always has many risks, and I will told you about later. So after you find the level, inject 1 ml contrast and check for intravascular injection. If there is no intravascular injection, you can inject your drug. And the fourth step, most difficult step, also not very difficult, is transforaminal injection with ultrasound. Transforaminal injection performed with different technique. As you know, classic subpedicular technique or through safe triangle zone, and the Cambian's technique, and the retroneural or periradicular technique. Transforaminal injection is still challenging, and pain interventionists are always searching for new technique to decrease the chance of intravascular injection and its catastrophic complication. Neurologic deficit can occur when the blood supply to a spinal cord compromised and present as anterior spinal artery syndrome. See here, this is anterior spinal artery syndrome, very devastating syndrome. And spinal cord ischemia, a stroke occurring during transforaminal injection may result from arterial embolization with air or particulate steroid, or from direct vessel injury as a spasm, laceration, and dissection. So transforaminal injection and even passage-on injection are very dangerous, and must always consider intravascular embolization and anterior spinal artery syndrome in your case. Okay, intervertebral foramen is a hole. This is a hole located between two adjacent vertebrae that allow communication between a spinal canal and external area, although it is used as a passway through the spinal nerve root and vascular structure. Knowledge of this vessel or the origin of the feeding artery are essential for interventionists. The most important radiculomedullary is the Adam-Cavis artery, which are found mainly in the region of thoracolumbar. Adam-Cavis is sometimes called greater radicular artery of Adam-Cavis. However, it is in fact a segmental artery. I will explain segmental artery for you later. And identifying the location of the segmental artery within the intervertebral foramen is very, very important. You see, this is the common site for the radicular artery. If you consider this foramen, you can divide it into the upper, lower, anterior, posterior. So anterior and superior part is the most common site for Adam-Cavis artery. This is the site when they first used transforaminal injection, enter needle here, but now they found that it is very dangerous. Okay. Regularly, transforaminal injection was carried out by entering the foramen at superior aspect, as I told you. A new study expressed, according to the Adam-Cavis artery location, opposed to normal base of transforaminal injection, recommended to locate needle in inferior and posterior part here. This is more safe. And today they say safe triangle zone is really not safe. And they reported that there is no significant correlation between pain relief and needle type position, retroneural, subpedicular, extraforaminal, junctional, or foraminal, and confirm the success rate is not dependent upon the distance between the needle tip and nerve root. Okay, You see here, this is very good view of the, this is aorta, this is lumbar arteries, segmental artery comes here and give a radicular artery here. And I want to tell you that this is the site that I used for Iran technique, and I will show you later. Okay, even as I told you, safe triangle zone is really not safe. The Campus triangle zone is also not safe. And there are new studies that show there are many cases of intradiscal injection with Campbell triangle and technique and intravascular injection. So it's better to use retroneural approach to avoid intravascular injection due to placing the needle lateral to existing nerve and farther from intervertebral foramen. And how we can use ultrasound for transforaminal injection. In 2007, Galliano described a technique and used the axial scanning of the spine. This is axial scanning. This is the spinous process, and this is SLP. Under it, this is foramen. He used exactly, it was a foraminal injection in 2007. And in 2011, Louis Zeid described a technique and used longitudinal scanning and sagittal view, and told there is a transverse process, and between them there is intertransverse ligament. You can pass the intertransverse ligament and you are still into the foramen. And after 2011, we have not new technique for ultrasound guided transforaminal injection because of the challenging of intravascular injection. Always we have challenging of intravascular injection, even with ultrasound. You see, this is intravascular injection. There is still insufficient clinical evidence to prove the safety of ultrasound guide injection as a sole image guide injection technique, especially for transforaminal injection. My great anatomy teacher, Dr. Mustaqimi in Mashhad University, taught me that there is always an artery and vein near every nerve. And I look for this artery near radicular nerve. And I try to find a way to use superiority of ultrasound to find vessel. So I told myself that if I could find the radicular artery, I could find the radicular nerve. So I studied about the anatomy and find this anatomy. As I told you before, here is aorta, here is a segmental artery separate from it, and then we have a spinal ramus, and anterior branch, posterior branch. You see, this is anterior branch to the anterior vasculate anterior vertebra, posterior branch vasculate posterior vertebra, and a spinal ramus which comes to the foramen and branch to the anterior radicular artery and posterior radicular artery. You see here, this is radicular artery. And what we see in Iran technique for ultrasound guided pre-radicular injection is not the radicular artery, because radicular artery is into the foramen, and we don't want to inject into the foramen. Exactly, we couldn't see it. What we see is a spinal ramus or segmental artery. This is a good view of the sagittal view. As I told you before, after you find the Z joint, as I told you, and it is very simple, move, your probe is put transversely. When you find the Z joint, move a little downward. When you move it a little downward, in a good device, you will see this pulse of artery. This is transverse process. This pulse of artery is visible here. When your device is not good like this and doctor couldn't help you, so you can use echo, pulse echo, and consider the device of the pulse echo. This is for spinal ramus. Okay, when you find this, enter your needle from here in plane toward this artery. See, this is the technique. The probe placed transversely, enter your needle in plane toward that artery and touch the bone. When you touch the bone, you can check it always like medial branch block in longitudinal scanning, And your needle today must be under the transverse process, as I told you, for medial branch block up to transverse process, and for periradicular injection down to transverse process, and then check it. And always at the last, you have to perform a live fluoroscopy. In live fluoroscopy, you can check for intravascular injection, not just a shot. In live fluoroscopy, and check if there was not any intravascular injection, inject. And this is very simple technique. It's not difficult. I ask you to perform this technique. And I used this technique for about 6 years. And I also published this technique. And because I always found that epidural injection has many complications, and I talk about all of this in my recent book, Safety Recommendation for Ultrasound Guided Spine Injection. This is published in Iran, and all the reference of all of I talk about you is in this book. Thank you for attention. Thank you very much.
Thank you, Helen. It's very amazing presentation, especially about the Iran technique.
Thank you.
Yeah, I already read it, your paper about it, and hope that someday you will directly teach me about your technique in Indonesia. Okay. Okay.
We
For
should
the
meet you in Jakarta in Kadaf workshop and proved it in Kadaf.
yes, sure.
Yes, yes, yes.
Okay, and then the next speaker, it will be Dr. Said Shofwan. I will read his CV. Dr. Said Shofwan, born April 10, 1981. Now he is working in the Sultan Agung Hospital in Semarang. He's one of the board of experts from fellowship in pain medicine by Indonesian College of Anesthesiologists, and he got the FIPP certification from WIP in Miami, Florida in 2017 in United States, and now he work a lot in the cancer pain mostly, and now I think he going to take his PhD in Netherlands, and for the times, please, Dr. Said Shofwan, you can begin your presentation.
Thank you very much, Dr. Yosi. Yeah, I'm preparing. Okay, good morning, everyone. Nice to meet you all in this session. I would like to perform my presentation under the title Fluoroscopy Guided Interventional Procedure in the Low Back Pain, Pitfalls and Potential Complication. Like what Helen has talked before, I think the fluoroscopy guided intervention is the ancestor of the ultrasound guided for intervention in pain management. Okay, I would like to explain about the fluoroscopy first as an introduction. We know that our body is a 3D construction, but the fluoroscopy picture is a two-dimension picture. So it is a challenge when we use a fluoroscopy as a guiding for our intervention. So the rule is we must reconstruct the 3D picture from at least 2D picture. So we recognize what we call multiplanar picture to do the intervention for a safety principle in intervention. look at this picture, yeah, like what Helen said before, this anatomy consists of many structure, not only bone, but also there are some nerve structure, and then vascular structure, another structure around here, a very crowded structure around the bone. But unfortunately, when we use the fluoroscopy as a guiding, we just find bone picture. It means that we should imagine the other structure in our fluoroscopic appearance. Where's this the nerve here? Where's the vascular here? Where's the epidural space? It is a challenge when we use fluoroscopy as a guiding in our procedure. So we recognize the statement bone is our friend when we use a fluoroscopy. What it means, we only use a bone picture to estimate the target structure or non-target structure around the bone correlated to our procedure. And also, we can use bone also as a guiding, for example, guiding for depth of the needle position, what we call hit the bone for our guiding to increase the safety in our procedure. You know that when we use the ultrasound, we can get the real-time picture, but when we use fluoroscopy, we cannot get a real-time picture except when we use the live picture or continuous fluoroscopy, but with the more risk of the radiation for us on the patient and also the other person around us. Okay, there is some complication in pain intervention in general. When we do the intervention, there is a potential complication that will be happen. For example, nerve injury and then vascular puncture, and this injury, subarachnoid puncture, subdural puncture, and when some of the vascular puncture complication are, we can difference between intravascular needle position or extravascular needle position. When our needle placed in intravascular, some complication will be happen. For example, toxicity of local anesthetic, especially when we use the high volume of local anesthesia, and also thrombus, and also air emboli, or like a particulate steroid emboli. But also when our tip of the needle are extravascular, there are some potential complication will be happen. For example, is vascular rupture or hematoma or bleeding. When our needle puncture the subdural, when our needle placed in the subdural space, there are some potential complication will be happen. For example, a high spinal block, especially when we use the high volume of the local anesthetic. The other potential complication of subdural puncture is the postdural puncture headache. There is a puzzle of safety in pain intervention. We should do all this item to get to assure the more probability of the safety for our patient. There is no single attempt to prevent the complication when we do the intervention. Number one is test dose. We can do the test dose to confirm our needle position, whether intravascular or intradural or intrathecal space. And then we should do the multi-planar picture. Multi-planar is mandatory, not optional, because like I said before, our fluoroscopy picture just 2-dimension picture, but our body is a 3-dimensional structure. The other one is we do the aspiration to confirm the position of our tip, needle tip, whether in intravascular or intrathecal or subdural or other else. When our needle placed intravascular, we can find blood in our aspiration, and then when our needle position is a subdural or intrathecal space, maybe we can find cerebrospinal fluid when we aspirate the syringe. The other one is contrast confirmation. It is very important because when we don't use contrast or we just make a plain picture from our fluoroscopy shoot, we can only find the bone structure. By using contrast confirmation, by using contrast injection, we can find appearance of the epidural space, radix, root, spinal nerve pattern, or vascular pattern on other else. The other one is stimulation confirmation, especially when we use nerve stimulation or when we want to do the block with the radio frequency. With the stimulation of the nerve, we can confirm the position of the nerve, the position of the tip of the needle to the nerve. It is too close or even intraneural, or still far from the nerve position. The other one is hit the bone. Hit the bone is something valuable for our guiding during the procedure, because before we get a picture shoot from the fluoroscopy, we can predict or estimate the position of the needle at the site from our target of intervention. And the most important one is patient monitoring during the procedure. For example, hemodynamic monitoring to control the blood pressure, heart rate, and other else. And also we monitor the patient consciousness. We monitor the patient sensoric appearance like paresthesia or even anesthesia and other else. So the role is to make sure that our intervention is safety. We must collect the missing piece to complete the puzzle. There is also the role of safety to do the intervention. The worst one is not safety and not accurate. There's the worst one. Yeah, it means that there is no pain relief of the patient, and the patient also get a complication. There is a worse condition. The other one is accurate but not safe, not safety. Yeah, maybe patient get pain relief but with complication. And the better one is safety but not accurate. it means that the patient have no pain relief, but patient have no complication. It means that no result of to the patient, no efficacy of the treatment to the patient. And the best one is accurate and safety. It means that pain relief without complication. This is the best one. This is the target of our intervention to our patient. This one maybe happen to the patient when safety but not accurate, yeah. But no pain relief also means that the intervention does not work to the patient, even the needle position or the procedure is accurate. There's the general potential complication of the procedure in the lumbar region. The first one is the paraplegia, and then there is epidural or subdural hematoma, and the high spinal or cardiorespiratory arrest, and pneumocephalus, and infection like discitis, meningitis, and the other minor complication. We start from the vascular puncture. How to identify the vascular in our during the procedure? The first one, we use the contrast. Use the contrast means we can do it with the two ways. The first one, we inject the contrast not using the continuous fluoroscopy image. And the second one, we use the continuous fluoroscopy image. The second one is test dose. We use maybe the local anesthetic and also adrenaline, yeah, to confirm. We use the local anesthetic to confirm the position of the needle, whether intrathecal or not. The other one, we use the adrenaline to confirm the position of the needle tip, whether intravascular or not. The other one is we do the aspiration to confirm the tip of the needle, whether inside or intravascular or not. And then we can also use DSA. There's two possible meaning of the vascular puncture. The first one is needle pierce the vascular wall and end of the needle tip is intravascular. The second is needle pierce the vascular wall and end position of the needle tip is extravascular. Helen has talked before about the Adamkiewicz artery, yeah, and he talked also about between the difference between the Cambian approach and the safe triangle approach. But one study from Murthy in 2010 proved that there are small probability, there's about 2% that Adamkiewicz artery were located in the lower third of the foramen intervertebral. It means that Cambian approach not 100% safe to for the vascular injection in our interventional procedure, like there is transforaminal injection. What is the pitfalls? The first pitfalls are not real-time contrast injection, cannot see the intravascular filling. When we inject the contrast, not using the continuous fluoroscopy, we cannot see the intravascular filling of the contrast at a real-time picture. There's a pitfall. It means that when we cannot see the intravascular filling, it doesn't mean that our tip of the needle not intravascular. The second is when needle pierce the vascular wall, there is extra and there is a tip of the needle are extravascular. Contrast not feel vascular, even though be injected under continuous fluoroscopy. There is undetected potential of vascular damage. The third one, aspiration. There is a possibility of false negative when we aspirate our syringe and we find no blood, but actually the tip of the needle are intravascular. There is a pitfall of this problem. There is an illustration between the tip of the needle are intravascular, syringe A. The second one is tip of the needle are extravascular. Both of the syringe, both of the needle are pierce the vascular, but the B syringe, the end position of the needle not intravascular, but the needle have a potential to disrupt or make a damage of the vascular wall. We should aware with this two condition or this pitfall. There is some complication reported at some in some case report, where in 2018, Benelux chapter of YAP make a review about the safety of steroid injection in transforaminal. They find 14 cases of paraplegia after the transforaminal injection of steroid, and most of the case found at the level of L3, and the lower from L3 level, they also find the complication of paraplegia in 3 cases. And also in L1 and L2, there are 2 cases, and at the level of L4 and S1, they find each 1 case. It means that all of the level of the spinal in the lumbar region have a case of paraplegia after the injection of the transforaminal steroid. It means that there is no safe, 100% safe of the injection of the steroid at the transforaminal lumbar region. The other complication is air embolism, especially when we do the interlaminar epidural steroid injection, when we use air for loss of resistance maneuver. And the other possibility is air embolism intravascular when we place our needle intravascular, and at the same time we cannot find the blood when we do the aspiration, or there is no spontaneous flashback of our syringe. So the alternative is to prevent the air embolism is we do the loss of resistance using saline or hanging rope technique. When we find the patient with very complicated condition, for example, after surgery, after spine surgery, there's a challenge for us to do the procedure at that level, because there's a fusion, there is a scar, there is also instrumentation there, so there's not easy to do the procedure safely and also accurately. There are some potential pitfalls. The first one, after laminectomy, the patient have a fusion and instrumentation, so that we cannot get a clear picture of the anatomy of the target intervention. The other one is change of anatomical structure, like a vascular epidural space. I think in this after surgery patient, the anatomy is not like the normal anatomy about the position of the vascular and also epidural space. There are some leakage or adhesion of the space. The other problem is dural puncture. Yeah, we know that the dural puncture means the needle is advanced beyond the dorsal epidural space, thereby the needle entering the central spinal canal. So that when we use a drug or a fluid to be injected, so the drug will spread around the space, and the effect is totally different with when the drug are in epidural space. There's a picture when the tip of the needle are in subdural space. You can see here there are three needles, the one at the level L4 and L5. The contrast spread around the nerve root, but at the level of L3, yeah, we see that the picture looks like normal, or looks like at the correct position. But when we confirm using contrast, the contrast spread contralaterally. It means that the contrast spread in the subdural space. There's a pitfall, something like normal, but there is not normal and have a potential complication when we continue the procedure. Okay. The other one is disc injury. How to identify the disc injury? The first one we use contrast, and then the other one we should examine MRI procedure. You can see this picture. When the patient has herniation, the herniated content spread to the foraminal space, so that when we use the Cambin approach in this condition, there is a the bigger possibility for the needle to puncture the disc at this level. So the pre-procedure examination of the MRI or the other tools of the picture is important. There is a disc injury during procedure. We can find the contrast spread intradiscal. It means that the needle tip are intradiscal place. There is also complication about infection, yeah. And then when there is a vascular injury, there are also potential complication like hematoma. So we should examine the coagulation profile before we do the intervention. We should ask the patient about the use of the anticoagulant drugs and other like aspirin, aspilate, and so other else. But I suggest you not to stop the drug personally, but consult to the cardiologist or the neurologist that prescribe the drug, because they are know better about the condition of the patient heart, patient brain, and so else. The other potential complication is nerve trauma. It happens when the tip of the needle hit the nerve structure, like the nerve root, spinal nerve, or even the spinal cord. We can prevent this complication using the contrast or nerve stimulation. When you stimulate the nerve, and the stimulation happen at the very low voltage, like less than 0.1, it means that tip of the needle are inside or too close to the nerve. It have potential complication of the nerve destruction after the procedure. So in my practice, I use the lowest limit of the stimulation, 0.15 volt. Yeah, there is a good picture of the wrong needle position. This one, a tip of the needle are at the left of the L3 pedicle, but the other one, at the right one, tip of the needle are intradiscal at the level of L3-4. We can confirm this needle position by with the lateral position. So we can find that the tip of the needle may be intradiscal. Yeah. How to make sure that the position of the needle are intradiscal? We use the contrast. When we use the contrast, we can see the spreading of the contrast intradiscal, and then the higher one, you can see the contrast spreading are subdural space. It is different. The contrast spread contralaterally at the subdural space, and this one, the contrast spread intradiscal. Okay. We talked briefly about the Cambian triangle and safe triangle. Like what Helen said before, there is no same efficacy with when we use the Cambian approach or the safe approach. But for the safety, when we use the traditional triangle approach or safe triangle approach, there is more risk of the vascular puncture with this technique. But when we use the Cambian triangle approach, there is a more possible complication about the this puncture with this approach. But for patients in whom the safe triangle approach is difficult, the Cambian triangle approach could be an alternative. You can see here the study that the 2% of the population have Adam carriage artery at the lower third of the foramen intervertebral. It means that there is no zero risk when we do also, even the Cambian triangle approach. Okay, what do you think when you find this appearance in your procedure table? Yeah. we can find in this situation, there is also probability, there is a problem about the scar or adhesion of the epidural. There is also, the target is disappearance by plate. And then there's a problem with alignment. And also, there is a difficulty for our needle access at that situation. And then contrast spreading is not ideal. And the vascular anatomy are also not normal. There's also same. There's a difficult situation. Sometimes we find the situation, yeah, we have no choice, but the safety is the first choice. This is the role of our work. There's also the best situation. Okay, it's multiplanar. Okay, thank you very much. Back to Dr. Yosi.
Thank you very much, Dr. Said. Yes, I want to give you applause. This is a good presentation. Very good presentation. Okay, this session will be Q&A session. So, I invite Dr. Said and Dr. Helen here. We have some questions from the participant. Okay, I will read it. The first question is from Dr. Ahmad Yassin for Dr. Helen. Dr. Helen, can we use ultrasound to assess suspicions of epidural hematome or abscess? Kindly share your tips and tricks, please. Okay, Helen.
Yes, it's possible, but you must be very expert. There are some lecture that pertaining to the some CSF leakage with pseudomeningocele and recognized after spinal surgery, and they saw it in spinal ultrasound screen. If you have just leakage, it is very difficult, but it's also possible at the hand of a very good expertise. But when you have an abscess or meningocele, it's possible to see it ultrasound, yes.
More easier for if you found an abscess, right, Helen?
Yes, it's possible. Abscess has when you have an space occupying a space in canal is possible to see with ultrasound.
Okay.
But it needs an expert sonologist.
Okay. The second one is, what is FBSS? Okay.
Yes, FBS I told during my speech. FBS is failed back surgery syndrome, a syndrome that we have after a spinal surgery. Yeah. And they always refer to us because of some complication or pain after the surgery, and we have to do some injection for them. Yes.
Okay. The next question is, okay, it's related to the COVID-19 pandemic. So what special precaution should be both for the patient side
during COVID time
at the COVID-19 pandemic? Yeah.
Oh, I wrote a lecture about this and will be published soon in Pain Physician. But I exactly used during COVID time, during these 3 to 4 months, I use a cocktail combination of normal saline, dextrose water, and ropivacaine or bupivacaine or lidocaine, and a small amount of dexamethasone.
Oh, so you small dexamethasone you use.
Yes. It's better to use short-acting steroid during COVID time, or not at all.
Oh, yes. Okay. So you're not using the long-acting steroid?
No. During COVID time, no.
Okay. Have you used any local anesthetic before insertion of needle?
Of course, you have to anesthetize because of the patient comfort. Of course, you have used local anesthetic and anesthetize when you want to enter your needle is large. So you must use local anesthetic before injection.
Okay, and then so this is how long with this procedure the pain does not, or I mean the pain disappeared, how long, and what the side effect if took a lot of procedure?
There are many complications due to procedure, as Dr. Said said, and I wrote all of them in my book. But we always afraid of intravascular injection, and I and Dr. Said talk about completely. But the relief depends on the patient. Most of time, maybe some relief after the injection happened, although we have pain at the needle side. But you have to work up your patient for about 2, 3, or 4 weeks after, and check again for the sign and symptom, because you know all of this injection is diagnostic. So you must check your patient if the symptom relief or not, and then consider another injection or consider medication. And always you have not to stop your medication after injection. And you must continue the medication, and then again check your patient and consider if you can stop the medication and your injection respond good. Yes.
Okay. This question, how to measure the testing dose? I think this is related to epidural maybe, right? How to measure the testing dose? What regimen maybe?
Okay, always in ultrasound guide injection, and I write in my book, you have to use test dose. Tests will help you to find the distribution of your drug. You can check it with Doppler, and this is the superiority of ultrasound. You can check it in Doppler and see the distribution of your drug. If you couldn't see the distribution, it's possible that you are in wrong place or you are intravascular. So it's very necessary to use test dose and then inject your drug. And it's better to first inject your local anesthetic and then inject your steroid for patient safety.
Okay. And the other question for Helen, do you advise to do facet joint injection, diagnostic medial branch block, and transforaminal Iran technique at the same long spinous process shadow area, or have different level to each intervention?
Exactly. When you use the Iran technique, and if you saw my video, I play with the tip of the needle and inject many sites at the same time. Ultrasound help you to decrease the time of X-ray exposure, because you just use live fluoroscopy at the end of your procedure. So you can use the Iran technique, use perpendicular injection. At the same time, you can change the tip of the probe at the up of transverse process and inject medial branch block. But when you inject periodicularly, it's very possible that you cover the medial branch too. So it's not necessary when you inject transforaminally at the same level, inject the medial branch too.
Okay. If we have previous laminectomy or fixation screw, what is your advice to overcome this artifact to get to target?
Yes, I always advise to use multimodal technique. As you see in the pictures, metal instrument cover the vertebra, and it's very difficult with fluoroscopy. But when you use ultrasound, you can use get a view of the foramen, get a view of the transverse process better. So I always use both of them, and it helped me very much. I have had many cases that the other physician couldn't inject because of this instrument, but with the help of ultrasound, I helped them and could inject. Yes, it's possible.
Yes,
ultrasound is very helpful.
It's very helpful that you use too,
yes, because you could give a view under the metal instrument and use that view.
Yes, I am experienced with that too.
Yeah.
So, would you be correct to assume that ultrasound is not recommended for guiding in transforaminal and or medial branch, since it cannot show? It cannot show, sorry, it's amazing. So it cannot show.
I talk all the time about that use ultrasound, but I always told you consider safety recommendation. When you use when you use ultrasound, it decreases the time of your procedure. My procedure finished after 5 minutes. You don't need to use many X-ray side, AP, lateral, oblique. You use just moving the probe, and then get a live fluoroscopy at the end when you find your goal. Okay, then a little contrast and check for intravascular injection or for the site of your needle. Sometimes in some patients it's difficult, exactly in obese patient, in degenerative joint disease of the spine, but you can combine ultrasound and fluoroscopy and help yourself and the patient. No X-ray, too much X-ray exposure, yes.
Yeah, starting with ultrasound and then confirm with the fluoroscopy, right?
Yes, yes. A very good technique.
And then for Dr. Said, this is the question for Dr. Said. When we know our needle is in extravascular in fluoroscopy guiding.
Yeah, that's not easy to answer because when we use the fluoroscopy, we put the needle and then after that we shoot, we make a picture. So when it means that we get a picture after we hit the vascular first, so that the best one to confirm is we use the role of the safety, like I presented before. We do the test dose and then we confirm the multiplanar and we use contrast and we do aspiration. I think all of that, like test dose, multiplanar position, aspiration, not confirm that the needle hit the vascular and the tip of the needle are extravascular. But we can also do the patient monitoring after the procedure. We should monitor about the neurologic function of the patient, like the motoric function, sensoric function, and other else, so that there is a puzzle of safety that we should do to make sure there's something difficult to confirm during the procedure, like the extravascular position of the needle.
Okay. The next question is, what is the underlying cause of this herniation? Okay.
For me?
What is the underlying cause of this herniation?
Oh yeah, yeah. There are so many risk factors for this herniation, like the weight bearing for the patient, always with the hard walking, yeah, with the weight bearing walking, and other else is the trauma, and also the age, and other else, yeah. So many underlying cause of this herniation, and also iatrogenic, like the missed procedure of our intervention when the needle hit this structure.
Okay, there's so many questions here. It's good. So this is the question from the new FIPP from Indonesia, Dr. Poppy Chandra. How long do we have? This is the question for Dr. Said and Dr. Helen, and also for me. How long do we have to evaluate the patient post-procedure to ensure that we are accurate? I think Dr. Said will answer this one.
Yeah, the principle of evaluation of after the procedure is there are two points. The first one is the monitoring of the efficacy. We can assess the pain scale of the patient, functional function of the patient, quality of life of the patient. The other one that we should assess to the patient is the potential complication that will be happen and the drug effect of that we use during the procedure. When we use the different drug, so maybe we should need the different time to evaluate. For example, when we use during the procedure local anesthesia, lidocaine, it is different when we use with the longer duration of the local anesthetic, like the ropivacaine and other else. It means that when we use lidocaine, maybe we should monitor the duration of the effect of the lidocaine, maybe half hours or 1 hour. It is early monitoring. But when we use the ropivacaine, maybe we assess the effect of the block, like motoric block and other else, a sensoric block, and also pain-free, longer than the lidocaine, and maybe 2-3 hours, even more. And then we should monitor the complication, but the potential complication that will be happen to the patient. For example, the early complication like the vascular emboli or vascular destruction, that can be happen early after the procedure in 1 or even 2 hours in or less. But maybe we also need to observe the delay complication like infection and other else. So there is an entity of the monitoring of the patient. So for the safety, the monitoring of the patient is mandatory, and how long, it depends on what procedure you did to the patient.
Okay. You give oral medication to patient after the procedure. What kind of medication do you give and how long?
Pardon me?
Do you give oral medication to the patient after the procedure?
Oh, okay. Yeah. Multimodality is better than the single modality, especially in the chronic pain. So when we use, for example, a procedure with the PRF, we cannot find the early effect of the procedure. At least we need 4 to 6 weeks for the optimal result or effect of the PRF. So before this 4 or 6 weeks, we need to cover the pain of the patient using the oral medication. Yeah, depends on the condition of the patient. You can use the WHO stepladder, and also you can use the adjuvant treatment like the gabapentin and also and other else. Just depend on your patient condition. So the multimodality is the best choice.
So this is last question. Which you prefer, safe triangle or cambit? Approach technique. Both of you.
In my practice, I often use the safe triangle approach because I use the RF or PRF modulation. But when and in my practice, I seldom use the steroid, so that so far, when I use the safe triangle approach, the patient is safe and no problem. But I don't want to say that there's the safest one. Yeah.
Okay.
Get back to the principle that we need to do the many point or puzzle of safety of pain in interventional management.
And how about you, Helen? Which you prefer? Safe triangle or cambit? This is a difficult question, right?
None of them. Periradicular injection.
Periradicular injection.
Yes, with ultrasound, it is periradicular injection.
Yeah.
And it's very effective. And even it's effective for pulse RF. I try many patients with this technique for pulse RF, and it was effective. It's not necessary to put the tip of the needle in dorsal root ganglion. When you put the needle near the nerve, you can pulse RF wave distribute around the needle. So it's also effective. But I didn't publish it. but in routine, I use just periradicular and even put pulse RF on the periradicular region.
Okay. So I think we finished the session and with the question and answer question. And then I'll give it back to Linda. Linda?
Yeah, doctor.
Yes.
Okay, so thank you to our faculties. What a wonderful presentation. If I could clap, I would clap.
Thank you.
Thank you everyone for also staying in and joining into the wonderful lecture. before we leave, there's some important information we'd like to convey to you all. First of all, we have next episode. All right, so this is a series of topic from the interventional pain updates. We have next week with a confirmation from Dr. Andre Manzano from Brazil. So make sure you stay tuned next week and don't forget to register. And also on the next episode, Dr. Agnes Togichka will once again be with us and talking about regenerative therapy on the 6th of July. So make sure you register also for that one. And during the session, we would also appreciate if you could give us your feedback. Right now in your screen, there is a polling that you could fill in right now. So please do so. For just 1 or 2 minutes. Thank you for those who have submitted. Thank you. And again, don't forget, if you'd like to register, we will give you the link for the registration for the next week with Dr. Andre Manzano on YosiAsmaraPain Talk next week, and also with Dr. Agnes Togichka on the 6th of July.
Yes, that will be good presentation and good topic from Dr. Andre and Dr. Agnes.
That's right, and hopefully Dr. Agnes also would perform her hands-on with patient. Well, this needs to be confirmed, but yeah.
Live demo.
Yeah, so don't forget. And once again, if you'd like to purchase the book from Dr. Helen, you can get in touch with the Academy. Here you go. Get in touch with the Academy, and then we'll help you to get some information on how you would purchase it. Thank you. So thank you, everyone. Thank you for the panelists, Dr. Said, Dr. Helen, thank you so much. Dr. Yosi, of course, thank you so much. And everyone, for the participants who have participated, thank you so much. We will see you next week. Thank you to all the crew, the organizing team behind the scene, and also the Escalop Academy Asia Pacific. Thank you so much. On behalf of B. Brown, Escalop Academy, and Pain Institute of Indonesia. See you again very soon, and goodbye. Thank you all.
Bye.
Yeah.